Our first guest of day 2 is the Chief Medical Information Officer and Senior Physician at the University Hospital of Frankfurt, Dr. Michael von Wagner. With the current pandemic, Dr. Wagner is a member of the coordinating hospital staff and project manager of the EGEPAN UNIMED project in the University Medicine Network. I think I said that correctly, for the development of testing and implementation of regionally adaptive care structures and processes for evidence-based pandemic management. Welcome, Doctor. The floor is yours.
First of all, I'm mute. Thank you very much for your nice invitation, and good morning to all of you. And thanks for the invitation to this very interesting conference. I am allowed to share our first steps in a project with which we are intended to improve the processes. We started this project together with our partner Philips already before the pandemic. Especially the part we are now talking about, the planning, the first milestones, because, and for that, please, the first slide. Next slide, please. Because not only a pandemic is needed to show us that the emergency departments face an increasing burden in the emergency process and sometimes become a bottleneck in this process because of a great variety of topics they have to solve every day. And this is not only the case in Germany or Europe, but as you can see on this slide, this is all over the world, even if the healthcare systems are quite different between our countries. The emergency departments obviously face the same questions all over the world. And for that, it is necessary that we start more and more to improve our processes to get more efficient, because at the end of the day, the processes also are involved in the question of quality and also the quality for every patient treatment. And one big issue in this is the time the patient has to stay in the emergency department. As you see here, it is especially all over the length of stay in the ED, which is increasing. And this not only means that the patient has to stay there and in this special situation, which is not a perfect situation for sick people to improve. This should be a short time of diagnostic and the first treatment, but then the patient should be moved to the at home, if possible, or to a ward where the patient get the rest the patient needs. But this time is also, or this increase in length of stay also leads to the situation that the emergency department is not able to let more patients in or new patients. And as we all had to face in the time of the pandemic, this led to far or long driving situations that the patients had to be sent to hospitals far away from home, and also needed a long time for until the first treatment could start. So it is important that we keep our EDs open, and this is done by shortening the length of stay. Please, the next slide. Let me talk a little bit about our own ED. The ED of the University Hospital in Frankfurt is a classical zentrale Notaufnahme, meaning that the ED accommodates all internal medicine departments and most of the surgical specialties. Currently, except of neurosurgery, but in next year we are planning to move also the neurology and neurosurgery department to our main campus, which means we will increase again the number of patients we have to treat in this area. Today already we are treating almost 50,000 patients per year, and almost 20% of these patients get admitted to our hospital. And not only the number of the patients we are facing every year is increasing in the last decade, but also the severity of the diseases the patients have is increasing. You have a kind of a split. The number also of patients with simple injuries, simple diseases are increasing, sometimes also because the patients do not want to wait for an appointment at the general practitioner, but also in consequence of the improve of treatment, the patients even with severe heart diseases, renal or liver failure, are living longer. This is our aim, but this also means the frequency of the time in hospital is increasing, and the patients are getting sicker if they come to hospital. And we also have to face that by the limited resources, the demand in quality and efficiency is also increasing by every single patient, but also by the society in general. And so there's, beside other steps, a need for early predictors that we can efficiently allocate our limited resources in an ED in the next years, beside the need of a accurate planning in a middle and long-term perspective. Next slide, please. So the first step should always be in an IT project that we bring all the people together, and especially that we bring the people we are doing it for together, meaning the nurses and doctors of the ED were included in a workshop we had here on a very hot summer day. You can't see that, but it was almost 35 degrees at this day. But we worked a lot the whole day and talked about the every single step in the process we focused on in our project. And on the left side, you see a general view on this, but we discussed every of these steps. We also discussed if we are already able to analyze these steps by a timestamp, if we have accurate data on this, or if we are still missing these data, or data are inaccurate, but I will talk about this a little bit later. And at the end of the day, we as you see on the right-hand side, we brought our own process on the wall and then selected KPIs we all agreed that we are interested in these in special. The next slide, please. And if we talk about this, we have to talk about the opportunities we have today to get accurate data on these KPIs. So the time arrival to provider, the time arrival to triage. Do we have these timestamps in our systems today? Provider to decision, very difficult question, because what is decision? What decision? We are talking about decision to departure. Do we have the timestamp for departure? What is departure? Is it the time the patient really leaves our hospital? Is it the time the patient leaves the ED? And do we document this accurately? And what does it mean for the process in a higher level of perspective? And at the end, and this is most common used KPI, length of stay. And what do we have today? We have the electronic medical records and also some timestamps by the medical emergency services. We have the laboratory information system providing very accurately timestamps, but do they fit to our processes or to the timestamps we are looking for? And this is the same for the radiology system. But what we already have, because we implemented over the last decade an electronic health record already in our hospital, we have it combined in the hospital information system. Please, next slide. So we first analyzed a time period, July until August 2020. And as you see the time, you see that we had to do this in parallel to the pandemic period. But fortunately, already last summer, we had a little break, so we could find time for that. And we analyzed more than 1,000 patients admitted in this time to our hospital, and we tried to analyze the length of stay and the time periods here mentioned. But we had also to realize that only around 10% of the patients had an accurate discharge timestamp. So obviously the health record was not sufficient to analyze all aspects of this study. And I can also add some other of these timestamps could not accurately be displayed by the just using the electronic health record. Please, the next slide. So what is this? What are these missing data leading to? As you see in the right side of the slide, the median length of stay was displayed with 13 minutes, which is obviously incorrect and is just caused by the missing discharge timestamp, which leads to a total misfitting of the data. And also some other timestamps did not be documented in the EHR, also caused because these timestamps are not the topic the documents are filled out for. So this is not the main question. The nurse or the doctor is asking themselves what was the correct time point, but they are just produced as a side effect of the running or of the use documentation. So it was obvious that we needed some other methods. But first of all, we had to analyze what are the reasons and what can be done for that. Next slide, please. So once again, let's talk about the reasons behind this. And first of all, what is the highest priority of our work? And I also, as senior physician, but also as resident, worked a time in the ED, so I'm very used to all of these reasons. It is not our topic to accurately document these time points, especially because most of them are not relevant even for documentation in the EHR. They are really just for the analysis of processes. And so the documentation is done if you have time for it and not done if you do the step by itself. So if you ask the patient, if you do the medical history, if you do some treatment, you will document it later. And if the patient can be dismissed, so you do not document when the patient really leaves the ED, you can stop by documentation of the patient report and send this out. So insufficient data quality, performance improvement is impossible by that. And the overworked staff also is not interested in improving that. Please, next slide. So what are the approaches of a project you want to reach? This is, first of all, you need a higher data quality, because otherwise you base all your plans and all your project steps on insufficient data and you draw the wrong conclusions. You need an integrated view, because you need to combine different sources of information, and this is very important, you need an automated solution so that you can remove burden from staff and not add any burden on them in addition, just because you need more accurate data. We all know these projects, someone is following a person who's working and documenting the data of every step. These are also inaccurate data, because this is not a really comparable way, and also a higher burden on the personal than an improve. It needs to be flexible, because workflows, and this is especially in an ED the case, workflows can change, and the last 2 years a lot of these had to be changed, and this will also be presented by me a little bit later, how we had to adopt our processes in the ED between the time of our workshop and then the time of the really running study. And it needs to be future-proof, so that we are able to adapt an interface and also the measurement on future technology opportunities. Next step, next slide. So the approach, high data quality, automating data entry improves, and what we decided to use was that we need location tracking, which allows us, without any additional entering of timestamps, to follow the patients and to locate the patients. And later also this improves the work for the people, because we can locate the patients as well as technical assets and provide these informations to the nurses and doctors. And we integrate, unfortunately, I see this slide only a part of, now it's better. Sorry for that. So we try to combine, first of all, the different data sources we had, a locating system, but also informations about the emergency medical services, which are provided in Hessen, which is the state Frankfurt is in, by a system called Ivena. We could use the medical records, and also could include some informations coming from our transport system. And we also included the perspective later to include further other techniques like Internet of Things, that we can combine these different data sources in a flexible, open, and AI-enabled platform. A dashboard including first-time data from really different sources, even from sources not part of the hospital, but like the medical service data, to get an integrated view and also to be flexible to adopt our system later. Next slide, please. So the first and largest step we did forward, because the EMR documentation we already implemented, but this had to integrated in the dashboard. But first of all, we had to implement a real-time locating system. And for the ED, we decided to use a room level accuracy and a high time granularity with 1.5 seconds, so that we can tag our patients up on arrival until they are dismissed or moved from the ED to the ward, or they can go at home. And we were able to get these locations mapped to stage of care. So we combined these data coming from the location system with the data coming from the EHR to a combined overview, and then to be able to choose the right timestamp for the process step to get the most accurate overview of the different several steps here mentioned. And on the left, you can see the patient tag we are currently using, which is very well accepted by the patients. This I really have to say, because we had some discussions in the beginning if the patients are interested or willing to wear these tags, but they were very interested, very open-minded to this, and we had almost no discussions about that. Even for children, that it was accepted by most of the parents. And at the end, and this was a really new step in our process, documentation of a step, we implemented this Dropbox. And this is really the time the patient is leaving, because in the moment he is leaving the ED, the tag is dropped in the box, and this is the timestamp sent to the system when the patient really physically leaves our hospital or the ED to the ward. Next slide, please. So what did we now get of KPIs? We got a time arrival to provider, patient arrival, which was mentioned also by the EMR documentation, but also by the tagging. So the first signal we received was the first timestamp, and the provider, meaning the first documentation in the system, or the arrival in the triage, as you see here. Arrival to triage. Triage is usually filled out after the nurses completed her examination, but now we had the time the patient entered the triage room, and so we really had a time arrival to triage because he was welcome by the nurse in this moment. We got a better length of stay time because we could measure the departure time accurately. And also we tried to get the provider to decision time, but this is something we still have to work on, because the decision can't be measured by the tracking. The decision is done by someone else. It's done by the physician. So this is something you really have to implement in the EMR system. But again, the decision to departure is a time we can more accurately measure now. Please, next slide. So here you see some examples of time we were measuring. First, in the beginning, I talked about the analysis opportunities of the EMR only. And as you see here, we had a very short length of stay in the EMR if we used only the data we received by the EMR documentation. Very nice, we can stop the project now if we believe in these data. But if we now add the location data to them, you can see the length of stay is much longer, and also there is an increasing number of patients with very long periods of stay, which is now more accurately driven. And as you also can see, if you take a look to the right, if we do these data or comparing the data combination and the data by the location, we have to see that the length of stay is almost completely documented by the location system alone, but by the EMR. So for the length of stay, as we also can imagine, the location data, because of the way we were measuring it, are the most accurate opportunity we have for that. Next slide, please.
Dr. Wagner, hello, thank you very much. That was incredible. I know there's a lot more to say, and there's a lot more that we can learn out of this. And thank you, by the way, for highlighting design thinking. So let me give the opportunity to promote that. You leveraged that during the session. We appreciate your feedback and many learnings there. One question, last question before we go. The emergency department has a huge impact on the rest of the hospital. Radiology, the wards, pathology, laboratories. Could you give us an indication of how you see that going forward, the interrelationship and anything we can learn there?
This is of very high importance, this question. Thank you for that, because we already had some other projects in the years before, and from then we had to learn, if you try to optimize the ED, and if you have a policy of open door and never send a patient back, you have a high impact on all other processes, for instance, for patients' elective planned in the hospital. And so you turn down all the other processes if you just take a look on the processes in an ED. So that one of the next steps has to be to scale up this project and to measure all other processes in addition.
Great. Again, thank you very much